Good afternoon. I am Dr. Katie Nayar. I bring you greetings from New Delhi, India. I am the senior consultant and head of department at Kangsha Eye Center in New Delhi. I am the immediate past president of Indian Fertility Society 2024 to 26. And I am going to give a talk on complications and risk in ovarian stimulation. This talk was given by me in the recently ASLM conference in Denver in the postgraduate course number 13, where we have talked about the ovarian stimulation. And this was one of my lectures there. And I'm going to talk about the same. The learning objective from this talk is we have to understand what is the potential complication to provide an overview of the common and rare complication associated with ovarian stimulation, including ovarian hyperstimulation syndrome, multiple pregnancies, and psychological impact on patient. And we have to explore the risk mitigation strategies, how we can reduce the risk associated with ovarian stimulation. And we have to emphasize the importance of patient counseling, highlight the critical role of patient education, counseling, and informed consent, ensuring that patients are fully aware of risk and benefits of ovarian induction. I have nothing to disclose. The complication occur in almost 2% of cycle in assisted reproductive techniques. This was said in ASHRAE 2008. They came out with this figure that 2% of cycle will have some sort of complication. The potential complication of ovarian stimulation are generally safe, but it can also lead to severe complication. This can range from mild side effect to severe medical conditions that require prompt intervention. And understanding these potential risks is crucial to both healthcare provider and patient to make informed decision. It is very important that patient can make informed decision. The complication of ART, it can be during ovarian stimulation, it can be during ovum pickup and embryo transfer, and it can be during after embryo transfer, immediately or late after embryo transfer, long-term complication and emotional stress. During ovarian stimulation, we can have hyperovarian response leading to ovarian hyperstimulation syndrome. We may have a poor ovarian response leading to cycle cancellation. We can have premature LS surge, and we can have drug intolerance. During ovum pickup and embryo transfer, we can have bleeding, we can have a pelvic infection or inflammation, and really pelvic abscess. We may have a difficult embryo transfer, and we may have failed fertilization and cycle cancellation. After embryo transfer, the immediate complication is OHSS. We're going to talk about it, pelvic infection, and implantation failure. The late complication can be again OHSS, multiple pregnancy, ectopic pregnancy, heterotropic pregnancy, miscarriages, preterm labor, fetal congenital anomalies. The strategy to minimize the risk, given the potential complication of ovulation induction, it is essential to employ strategies which can minimize the risk. So you have to individualize the treatment protocol. You have to select the patient. Not all patients are suitable candidates for aggressive ovulation induction protocol. It depends upon the age, the body mass index, ovarian reserve, and underlying medical condition that we should carefully consider. And while designing a treatment plan, we have to adjust the dose also. The use of low dose gonadotropin and careful titration should be used in the, for patient to reduce the risk of OHSS. We have to do a frequent ultrasound transvaginal monitoring to allow for assessment of follicle development, helping to identify the patient at risk of OHSS. And it does need some hormone monitoring like serum estradiol level commonly measured to gauge the ovarian response and adjust treatment as needed. So all these are the things we employ to reduce the risk of complications. The ovarian stimulation protocol, most of us are now shifted to GnRH antagonist protocol because it is associated with low risk of OHSS compared to traditional protocol, the GnRH agonist. And antagonist protocol is especially beneficial for patients with polycystic ovarian syndrome and those with high ovarian reserve. The trigger also, we can use agonist trigger instead of SCG in certain protocol, and it can reduce the risk of OHSS as it leads to shorter luteal phase and less sustained ovarian stimulation. Now we are going to talk about ovarian hyperstimulation. During ovarian stimulation, the ovaries are producing a lot of steroids and variety of vasoactive substances, which alone or in concert create a hyperpermeability state causing sign and symptom of OHSS. Mild form of OHSS is common in almost 33% of IVF cycle, and 3 to 8% of IVF cycles are complicated with moderate and severe OHSS. These are the various degrees of OHSS we can encounter during ovarian stimulation. The pathophysiology is basically the result of vasoactive mediator being released from hyperstimulated ovaries, and SCG play a key role in mechanism of OHSS by mediating the release of vascular endothelial growth factor A, which is causing the capillary permeability is increased, causing the extravasation of fluid from intravascular compartment to the third spaces. Type of OHS, there are two types: early onset, which develops after pre-retrieval SCG injection, and the late onset, which develops after 9 days when the treatment is successful and pregnancy has happened. And if the treatment doesn't lead to pregnancy, early onset OHS usually resolve on its own within few days. And the late onset OHS, because it is happening after the pregnancy has occurred, so it will stay there. So you have to take care of the various problems with the late onset OHSS. The risk factor, the primary risk factor is age less than 35, low body weight, PCOS, previous history of OHSS, high AMH more than 3.36 nanogram, or high AFC. All these are the high risk, the primary risk factor for developing the OHSS. The secondary risk factor is a rapidly rising E2 level, large number of developing follicle on the day of SCG, more than 20, use of SCG for luteal support, large number of oocyte retrieve. If you have more than 20 oocyte retrieve, the patient is likely to develop OHSS, and if there is early pregnancy. The various grades of OHS is mild, moderate, severe, critical. These are the various presentation of mild. It is abdominal distension, discomfort, mild nausea, vomiting, diarrhea, enlarged ovary less than 5 cc. The moderate has this same feature of mild plus ultrasonic evidence of ascites, hematocrit is more than 41, WC count is more than 10,000, hyperproteinemia, enlarged ovary more than 5 cc. The severe is clinical evidence of ascites, massive ascites. There is hydrothorax, hematocrit is more than 45%, WBC count is more than 15,000, oliguria, creatinine more than 1.5, creatinine clearance is more than 50 ml per minute, and hepatic dysfunction can also develop. And the critical stage is tense ascites, hypovolemia, pericardial effusion, arrhythmias, hematocrit more than 55, WBC more than 25,000, renal failure, creatinine more than 1.5, and creatinine clearance less than 50 ml per minute. Prevention, how can we prevent OHSS? The primary prevention is reducing the gonadotropin dose. This favor a step-up regime. Reducing gonadotropin duration, we have to reduce the number of days patient receives gonadotropin through mild stimulation protocol. Individualizing IVF treatment regime, use of progesterone over SCG for luteal support, agonist for ovulation trigger, and we can use metformin 1,000 to 2,000 milligram at least 2 months prior to ovarian stimulation recommended. The secondary prevention of OHSS, you can do coasting if you are having a sign that patient are going to OHSS, then we do coasting. You can withdraw the gonadotropin till the certain E2 consideration is achieved. We can give a agonist trigger followed by cryopreservation as the most effective method in preventing OHSS. This was propagated by Paul Devroy and this type of protocol that you do compartmentalization, you do ovarian stimulation, you do pick up, you freeze the eggs and transfer, do a frozen embryo transfer in the subsequent cycle. And agonist trigger is being used. And cycle cancellation and withholding HCG is the only definite method, but it is painful, emotionally painful for both patient and the doctor. So we don't like to cancel, we like to use the safeguards so the patient doesn't go into OHSS, and you can use a called over a method that you can do a stimulation, you can give a agonist trigger, you can do the oocyte retrieval, freeze all, and then subsequently transfer it. You can give colloids and like albumin and hydroxyethyl steroids, or you can give him dopamine agonist as cabergoline. These are all secondary prevention. Treatment, mild OHS, this patient needs reassurance. Moderate OHS, patient need bed rest and abundant fluid intake. Severe OHS, you have to monitor pulse rate, BP, abdominal girth, weight, fluid intake, output, hematocrit, and hospitalization treat with IV crystalloid. If hematocrit improve, continue the same treatment. If no improvement, add colloids. If renal parameters are normal with severe oliguria and severe ascites, do paracentesis. And if there is no improvement, you have to give dopamine drip to improve renal perfusion and thromboprophylaxis. All these are critical care. Patient has to be in the ICU and patient needs to be proper follow-up. The best practice and research in clinical and endocrinology and metabolism, it was published by Santos Roberio, Sherry Mackins, and Christopher Bolkiel. They said that the incidence of most of these ART-related complications is associated with how women undergo ovarian stimulation. So for this reason, physicians should be aware that a carefully thought out ovarian stimulation protocol and cycle monitoring are of paramount importance to maximize the success of treatment while avoiding potentially life-threatening complications to occur in this frequently otherwise healthy patient population. So these all patients are healthy. They come to us for infertility, and we cannot lead them to a situation where they become a life-threatening situation. The ovarian stimulation related complication and which are associated with OHSS, the overall risk of thromboembolism is 0.04 to 0.2. With OHSS, it increases to 4%. Administered torsion also 0.08. It can increase to 3% with OHSS. Lobar pneumonia, ARDS, pulmonary embolism, and in rare cases, death has also been reported. So all these are complications, which is the incidence of complications increasing with the patient develop OHSS. Complication during oocyte retrieval, vaginal bleeding from vaginal vault, it can happen in 1.4 to 18.4%. It can stop spontaneously by pressure, or you can do a vaginal packing, or sometimes you have to take a suture also. Intra-abdominal bleeding, incidence of severe bleeding is very less, 0 to 1.3%. Lean patients, PCO is at high risk, and acute hemodynamic deterioration can happen. Then you have to take Nayar, probably you have to perform a laparoscopy or laparotomy. Similarly, retroperitoneal bleeding or hematoma, a case of retroperitoneal hematoma was reported after 10 hours of home pickup, and there was hematological estimation and ultrasound. The appearance of periumbilical hematoma colon sign, followed by ultrasound guided transvaginal oocyte retrieval. The management is again laparoscopy or laparotomy. Trauma to pelvic structure can also happen, and pelvic infection can happen. Tubo-ovarian or pelvic abscess incidence is 0.2 to 0.5%. The management is you have to give intravenous antibiotic, rarely synthesis or laparotomy. Routine use of IV antibiotic prevent the complication. Ovarian torsion, we have mentioned that when the patient develop OHSS, the incidence of ovarian torsion increased to almost 3%. And this is a rare and serious complication when ovary surround the ligament that support it, cutting his blood supply. The patient may experience sudden severe abdominal pain, nausea, vomiting, and ovarian torsion is surgical emergency require immediate intervention to preserve the ovarian function. The risk of ovarian torsion increases with size and number of ovarian follicles stimulated during ovulation induction. This is a picture of ovarian torsion which has happened in the asymmetrically left ovary, which is located in the midline within the cul-de-sac. The uterus also demonstrates a leftward deviation, which is another secondary sign of torsion. The right ovary was identified separately. So this is a ovarian torsion happening in the left ovary. Following this, there can be miscarriage and ART. The incidence of biochemical pregnancy loss is almost 15 to 20%, which is as good as is happening in the spontaneously conceived pregnancy. The incidence of clinical pregnancy loss is almost 10 to 45%. In a spontaneously conceived pregnancy, it is 10 to 15%. Overall, 30% of UPT positive women will lose their pregnancy within the first trimester. And the incidence of late pregnancy loss, that is after 12 weeks of gestation, is almost between 2 to 4%, which is also higher than that of a spontaneously conceived pregnancy, where the incidence is almost 1%. The risk of ectopic pregnancy is also there, which is also twofold higher in IVF ET pregnancies. And the incidence of ectopic pregnancy is 1 to 3%. The tubal pathology, previous tubal surgery, pelvic inflammatory disease are a risk factor for ectopic pregnancy, and patient can present with amenorrhea, abdominal pain, and abnormal vaginal bleeding. These are the risk factors for ectopic gestation. If the patient has a history of tubal damage, history of tubal surgery, underlying tubal pathology, if you use large volume of media for embryo transfer, impaired tubal function, previous history of ectopic pregnancy, peritubal adhesions, pelvic lesions, developmental abnormality of tube, higher frontal placement of the embryos. This is the possible factor associated with ectopic pregnancy and how we can prevent. If the patient is having tubal disease or hydrosalpinx, you have to do pre-IVF salpingectomy or tubal occlusion. When you are doing embryo transfer, you have to check the depth. You have to do a mid-frontal transfer, ultrasound guided. And amount of media used should be 15 to 20 microliter. The number of embryo, the reduced or single embryo transfer should be done. And day 3 or day 5, the data suggests fewer ectopic with the day 5 embryo transfer. Diagnosis: inappropriate rise of beta HCG, transvaginal ultrasound, lack of intrauterine injection sac in TBS when serum beta HCG is above 1500 IU. Management is medical management by methotrexate, or this is again showing this ectopic pregnancy in this patient. And again, right diagnosal ectopic pregnancy is seen. And if a patient has ectopic pregnancy, either you give methotrexate, and if patient it doesn't resolve, you can do a laparoscopy if patient is hemodynamically stable. If it is unstable, you may need to do a laparotomy. The procedure performed can be salpingostomy, segmental excision, salpingectomy. There is risk of recurrent ectopic pregnancy in salpingostomy and salpingectomy. The incidence recurrence of ectopic is less. So when you do surgery, you have to do a salpingectomy because then the incidence of recurrent ectopic reduces. Heterotropic pregnancy can also happen. Incidence in natural conception is 1 into 15,000 to 1 into 30,000, while in ART it is almost 1 into 100. And if you are transferring more than 4 embryos, the incidence of heterotropic pregnancy is 1 is to 10. In heterotropic pregnancy, 1 pregnancy is in the uterus, 1 pregnancy is outside. So after treating extrauterine pregnancy, the intrauterine pregnancy will continue in almost 70% of the cases. This is the heterotropic pregnancy following IVF, and this uterus revealed to gestation sac A and B, and cardiac activity not shown. This is heterotropic pregnancy. Again, another heterotropic pregnancy, intrauterine pregnancy with a yolk sac and addition gestation sac with a yolk sac near the cervix. The risk and complication in ART. The consensus meeting on risk and complication in ART held in New Zealand in May 2002 basically focused on 4 topics. There was the multiple pregnancy, the long-term effect of ART in women, the effect of ART on the offspring, and morbidity and mortality registry. The outcome measure of ART and non-ART should be a singleton live birth rate. That is important. That we should be aiming for a singleton live birth rate. Multiple pregnancies, use of ART carries substantial risk of multiple pregnancy. The HEFA statistic from UK 2011 showed the risk of twin pregnancy almost 19.8%, 1 in 5, and incidence of triplet and higher order was also high, 4 to 5%. The increased risk of maternal and fetal morbidity and mortality associated with multiple gestation as a result of preterm birth, preeclampsia, and other pregnancy complications is also described. We can also have a more chances of monozygotic twins in ART. And the issue with multiple pregnancy is the preterm birth. And you can have an early term birth within 37 to 38 weeks is also associated with adverse neonatal outcome, primarily respiratory problem. And the fetus brain development rapidly in the last 4 weeks of gestation. So there is increased risk of abnormality of neurological and intellectual function in children born between 34 to 36 weeks. which become more profound if the delivery is happening before 34 weeks. So this is the problem with multiple pregnancy. How to reduce the multiple pregnancy during ART? You can either shift to elective single embryo transfer. Selection of appropriate patient for single embryo transfer is important. Choose the best embryo and better method to assess embryo quality and viability. You have to do a proper aspiration and vitrification of the embryos, monofollicular development in IUI cycle. And if there is a multiple pregnancy, you can do a multi-fetal reduction. And in IUI cycle, you can shift to IVF cycle. Elective single embryo transfer in Europe has shown that the selected group of patient pregnancy rate after single embryo transfer equal as much as to double embryo transfer. That was the finding from two authors, Garis and Markanen. The patient selection and counseling for elective single transfer, the consensus are the elective single transfer should be performed if twin pregnancy is contraindicated or if patient wishes to avoid a twin pregnancy. Elective single embryo transfer should be proposed in the first or second IVF cycle in a woman less than 36 of age, or if at least one good quality embryo is available. The embryo selection, each laboratory should have its own reference value based on the proven implantation rate. Embryo should be checked at 400 magnification at fixed intervals, and any deviation from normal development rate should be recorded. These are the ASRM guidelines on the number of embryo transfer. If you look at the age, any woman less than 35 years of age, the recommendation is to transfer single blastocyst. If a woman is more than 35 to 37, you may transfer two cleavage stage or two blastocysts. If a woman is 38 to 40, you can transfer two blastocysts or three cleavage stage. So it all depends upon the age of the woman, how many embryos you should transfer. Less than 35, good quality embryo, single blastocyst is the need of the hour. The long-term effect of ART on patient, cohort study in Netherlands, after a follow-up 5 to 8 years, there is no increased risk of breast or ovarian cancer was found in women who has undergone IVF. So you can reassure the patient that there is no risk of developing breast or ovarian cancer in women who have undergone IVF. Similarly, there is increased risk of endometrial cancer was observed in patients exposed to IVF as well as in unexposed groups, suggesting a subfertility related effect which needs further evaluation. That was also reported in the year 2000. So we have to do further evaluation whether patient has increased chances of increased risk of endometrial cancer or no. The long-term effect on offspring, the effect of ART on offspring, a significant increase in sex chromosome aberration is seen, particularly after ICSI, and the risk of congenital malformation after ART is increased as compared to natural conception. In ART, it's 5.4% versus 3.8% in natural conception. Absolute risk of major congenital abnormality is small and is not different between IVF and ICSI. They are same incidence of congenital anomaly. Reverse perinatal and neonatal outcome in ART are due to underlying cause of infertility, use of drug for ovulation induction, and luteal support and ART procedure. The congenital anomaly which see is either it can be major birth defect, which can be because of increased maternal age, or during IVF, the embryo is exposed to mechanical, thermal, and chemical alteration, or there can be chromosomal anomalies. The risk is higher in severe male factor infertility and unexplained female infertility, or there can be imprinting disorder, defect in process of genomic imprinting leading to congenital disorder in baby. Certain genes from either mother or father are commonly switched off. The imprinting phenotypes such as Silver-Russell syndrome, Backwith-Wildman syndrome, or Engelmann syndrome is increased in ART population, but the actual risk for one of these phenotypes to occur in assisted pregnancy is estimated to be low, less than 1 in 5,000. Exact biological etiology for this increased imprinting is likely heterogeneous and require more research. Fetal congenital anomaly in ART pregnancy increased risk is mainly because of high risk of multiple birth. They have found out that children born after ICSI, the incidence of hyperspadias is more. The relative is 3, and which may be related to paternal subfertility. The other problem of childhood cancer, ovulation induction with ART, the relative risk of childhood cancer was 1.3 in IVF and 1.4 in ICSI. 3% of Greek and 2.7% of all Swedish children born having leukemia were conceived through IVF. So few studies reported an increased risk of neuroblastoma, retinoblastoma, and hepatoblastoma with ART. So these are the few risks we have to discuss with the patient. Reproductive technology and risk of birth defect. ART is associated with 1.5 times increased risk when compared to spontaneously conceived pregnancy. The risk of IVF is 1.07, risk of ICSI is 1.57. Vast majority of births resulting from ART are free of birth defect. However, treatment of ART was still associated with higher risk of birth defect compared to spontaneous pregnancy. Much remains to be established regarding biological, psychological, and social outcome of ART-born children. We need more long-term studies. The association between ART and risk of autism spectrum disorder, published in 2017 by Liang, and he said the use of ART is associated with higher percent of AST. The relative risk is 1.35. And preterm delivery appears to be mediating factor in ART-associated autism association, and significantly increased risk is also seen after ICSI procedure. So these are the preterm delivery and ICSI procedure itself are causing the increased incidence of autism spectrum disorder. We have to, according to the Netherlands meeting in 2000, we have to maintain a morbidity and mortality registry, and we have to check for maternal and fetal morbidity and mortality, pregnancy complication, zygosity in twin pregnancy, congenital malformation, multi-fetal reduction, new procedures, new ART procedures. So we have to maintain a registry for all this so that we can have data and we can analyze the data to see how we can improve our procedures. The psychological and emotional complication, the physical risk of ovulation reduction are well documented. The psychological and emotional toll cannot be underestimated. It can cause high level of anxiety, particularly around the time of oocyte retrieval and neck transfer. And if you have an unsuccessful cycle, the emotional burden of unsuccessful treatment can lead to depression, feeling of inadequacy. And what you need to do a comprehensive patient counseling. You have to communicate risk in a very clear and understandable manner, avoiding the medical jargon. That is important. You avoid medical jargon. You communicate with the patient in a very understandable manner, and you have to set realistic expectation. Patient shouldn't think that every IVF procedure is going to give a guaranteed pregnancy. No, you have to give them the very realistic expectation. What is the possible chances of pregnancy with the IVF? So patient is prepared to accept the failure or success as per the counseling. You have to give an informed consent. The consent should cover the nature of procedure, the risk, the benefit, the alternative option, including no treatment, and the potential outcome. Patient should also be informed of their right to withdraw the consent at any time. And proper documentation of the informed consent is essential. So this is very important. Informed consent is not just a legal document, but an ethical imperative that ensures patients are fully engaged in the treatment decision. And there should be shared decision making, and the collaborative approach can lead to higher patient satisfaction and better adherence to the treatment plan. We should do a shared decision making, which all the patient and healthcare provider working together, and you empower the patient by providing patient with information and support they need to make informed choice. In conclusion, the ovulation induction is a powerful tool, but it comes with a set of risks that must be carefully managed. By understanding the potential complication, employing strategies to minimize the risk, ensuring through patient counseling and informed consent, healthcare provider can optimize outcome and safeguard the well-being of the patient. And the balance between efficacy and safety is paramount, and continuous education and communication are essential in achieving this goal. Thank you. Thank you very much. If you got any question, feel free to ask me.